right, so let's do this case. Let me see how I can open up all of you guys, girls and guys. That's all right. So we have a case here. So let's do it the same way that we reviewed in class. So the first thing we're going to look at is what part, like the S4, S5 level, right? On the bottom. So what is this? Is in Asia A, B, C, D, or D?
A.
A for sure. So great. Great job. So now let's look at the right sensory level. So what's the right sensory level? Can somebody give me a level?
C7.
C7. Perfect. Great job. Left sensory level.
Would it also be C7?
Yes, it is. Great job. Was the lowest part where there's two twos, where there's still intact sensation. After that, there's not two twos. All right, so what is the right motor?
I'll go with C6.
Yes, you are 100% correct. Great job. Yes, because it has to have a 5 on top, so it has to have an intact innervation. Remember that both branches have to be innervated, so for each of those muscles. So, and then the number under it has to be a 3 or higher. So that's 100%. Plus the sensations are all 2s on the side. What's a left motor? I almost feel like I'm like in a what is it, like a TV show, you know, like what is the answer of this? What's the left on the left side? What is the motor level on the left side?
C7.
D7, great job. Excellent. So what is the neurological level of injury for this individual? Remember, it's the most C6, great job. C6, and then what would be the full product if you had to give C6 Asia what?
C6 Asia A.
Excellent, perfect. How is that? Thumbs up, good, bad? I'm still confused. I need more practice. You want to do one more? One more. Let's do like an incomplete one. Let's see. No, this one's a complete injury too. Give me 1 second. Hold on. Okay, this one's a fun one. So if we're seeing on the bottom that it says at the S4, I don't want to put it too low because then I'll give the answer. At the S4, S5 region, we see yes, 2, 2, 1, 1, yes. That means that this is not a what? It's not a...
It's not a complete.
It's not a complete. So now we have to see if it's Asia what? B, C, or D, right? So we go the same cycle again. Start on the right side. What is the right sensory level?
Don't they have full sensation?
They have full sensation, exactly. So they have full sensation on the right side. Perfect. Left side, what is the sensation level?
C8.
C8, great job, excellent. So right, you have that written down. Now, what is the motor level on the right side?
C6.
C6, great job. Yeah, there's a 5 on top, all are 2, so sensation is intact, and it's a 3 or higher at the C6 level. Great job. What about left motor?
C5?
C5. I don't hear the confidence. Why C5?
Just because below it at C6 is a 2. So I was thinking like I think it's just C5 then.
Yeah, because the rule is it has to be a 3 or greater on the bottom. Remember that the Asia is a very foolproof test that in order for them to say that that muscle is innervated, it has to be at 2 levels. Remember that most, well, if not all of them are innervated by at least 2 levels. So yes, it is not C6 because it is a 2. If it was a 3, then it could be C6, but it's not. So it has to go the level above. So that's C5, right? So what is the neurological level of injury for this patient?
C5.
C5, exactly. Great job. All right, so now you guys tell me if anyone can give me a thorough explanation as to, is this an Asia B, C, or D? You could take a little bit of time to kind of brainstorm in.
Okay, I think I have an idea.
Okay, what's your idea?
So would it B, because they don't have like at least 50% motor, but they do have sensory? Is that the right track, or am I confusing things?
Well, what was your answer? B?
Yeah, B.
Okay. Does anybody else agree or disagree with Hunter's answer? I'm not putting you on the spot. I'm just putting it out there to the universe.
It's okay.
I was thinking maybe it was Asia C.
Why? Why, John?
So for Asia B, I know that you need to have sensory and no motor. It looks like there is sensory and motor. So I went to Asia C where I looked at the NLI, which was C5, and looked at all the key muscle groups, and less than 50% of the muscle groups below the NLI on both sides were working pretty much, or I guess more than three. So that led me to think that it was Asia C. But I might be wrong.
No, it's fine. I'm just putting it out there. Then I'm gonna clarify everything. So Hunter, you're saying B, John is saying C. Does anybody else have another thought process or anything about this? Any questions? Any ideas? Two brave souls on here. Anybody else?
I also
What's
think it's C for the same reason, because it's not strong motor, but they do have motor and sensory.
Is that Stephanie? Maybe I don't
Yes.
know. Yeah,
Yeah,
I
it's
know
the
your voices. I know some of your voices. I just can't see you on the screens. Okay. All right. So what is the definition of B? What is the definition of B? So right here in the back it says, what does it say? Sensory but not motor function segments S4, S5, right? And no motor function is preserved more than 3 levels below the motor level on either side of the body. All right. So we have to see if the motor function is preserved more than 3 levels below the motor level on each side. So what were the motor levels? We had C5, right? Then we still have motor preserved. How many? 1, 2, 3, 4. We still have over here. And then over here, what was it? We said C6, right? This one's only 3 levels right here preserved. So this one is actually a pretty confusing one for you guys, right? Because you only have like a 1 over here on the other side. Some people are arguing that it's Asia C from a motor incomplete standpoint, meaning that we go by the key muscles. For my students, I always told them to go by one of the definitions. Don't go by either C or D. You always have to go by one definition. All right. So now after seeing this, especially this one, sensory, it says sensory but not motor function is preserved below the neurological level and includes the sacral segments of light touch. All right. So is it B or is it C, depending on this? I'm going to throw it back at you guys. I know the answer because I have the answers with me. But what is the answer?
Isn't it that as soon as you see VAC, you know it's not going to be a B because they have the voluntary, contraction. So that, like, once it says yes, it's going to be a C or a D. But if it says no, then it could possibly be a B.
I wouldn't go exactly by that rule per se, 100%, but it is a way to look at it 100%.
Okay.
You're saying that because there is some, what did you say? Voluntary anal contraction from the
Yeah.
motor point.
hmm
You're pretty much on the right track. Yeah, this would be an Asia C, guys, not Asia B. If not, it would just be preserved 3 levels below the motor wise. There's still more motor preserved 1 level below that. Does that make sense?
Yes.
Questions, concerns?
Can you explain it one more time about why it's Asia C?
Yeah. So you have to look at the one for Asia B. So Asia B says sensory but not motor function is preserved below the neurological level and includes the sacral segments S4, S5, light touch or pinprick, or deep anal pressure, and no motor function is preserved more than 3 levels below the motor level on either side. So the thing that throws it off is that there still is some motor preserved at the T1 on this side, because if not, we would follow the rule of 3 levels, but where there's still some motor here preserved. It's depending on the motor level on each side. This one only has 3 levels over here, but there's a little bit more preserved on the right side. This one's a very confusing one for you guys, to be honest with you guys. Here, let's try one more. A little bit, probably less confusing. Okay, this one's a lot more straightforward. What is the sensory level on the right for this one? If somebody has written it in the chat, I cannot see. Hold on.
Full sensation.
Hold on. Sorry. Let me go back. Right. Yep. Full sensation. Left side. Left sensory level. Full sensory, right? As well, right? Motor on the right.
Is the L3?
Yes, sir. Great job. All 2s all the way down. Remember, do not forget to look at the muscles that do not have, like, do not look at the areas that do not have a muscle attached to it. Yes, and there's a 4 and there's a 5 on top and all 2s. Great job. Left side. Remember
No.
that it, yes, sorry.
L4.
L4, great job. Yeah. The most common mistake that students make on this exam is not knowing how to get the levels, is getting the right and the lefts right. Honestly, that's really like, and you know that one of the distractors of the choices is going to be the other side's level. So keep that in mind when you're looking at it. All right. So what is the neurological level of injury for this patient?
L3.
L3.
L3. And then what is it? Asia A, B, C, or D?
Asia D.
100%. You could already kind of like, and if you go by the rules, remember that you're going to draw a line under that neurological level of injury, right? So what did we say was the neurological level of injury? L2, right? And then you're going to count how many of those muscles are still, how many muscles are there? There's 1, 2, 3, 4 on each side, right? So that's 8. And then how many of them are at least a 3 or greater? And you're going to see that 5 out of the 8 of them are a 3 or greater. So that means that the Asia D rule, that 50% greater than or equal to 50% of them are a grade of 3 or 3 out of 5 MMTs. So that's why I always tell you guys, memorize one of the rules. You either memorize C or you memorize D. If you memorize both of them, it's a mess, to be honest with you. Okay, I'm gonna stop sharing my screen. Did it stop sharing? Yeah. All right. Talk to me. Okay, that's a little bit of Asia. A little bit of Asia for you guys. What else would you want to target from spinal cord? I know you guys you had your spinal cord practical today, so that kind of like closes off the unit. Hello, do you feel better with that? A little bit better?
Yes, I do. Thank you.
Still review it. It's about 10 questions on your exam.
Dr. Quinones.
Yes.
Hi. You mentioned the to know the chart with the bracing, but
Mm-hmm.
I thought I knew what you were talking about and I can't find it.
Okay, it's on the gait lecture. Hold on, let me open up something else. Give me 1 second. I'm not sharing my screen, right? No, right?
No.
I'll double check. Give me 1 second. Looking for something else for you guys, like an extra resource. Give me. Okay, if you go, let me share my screen now. If you go to the gate one, the gate PDF under announcements, then on here, see bracing. So I asked some students the question today of like, can you what is the level of injury that you could like gait train at and stuff like that. So ideal is anything from T6 and below. Think of like full upper extremity function plus some abdominal control as well. So that's the most ideal for injury. But in reality, the chart is this one is what I'm talking about, the brace options. So I think I asked one of the students that at C7 if they had the capacity to ambulate, and no. Anything greater than C8, they cannot ambulate, but from T1 to T9, they can ambulate for exercise. So it's not very functional. As you can see, you don't really see a lot of people out in the community with AFOs, I always have the hardest time saying this, and HKFOs. They're just very cumbersome. They weigh a lot. You will not see a lot of individuals in the community if you ever see them. You will see this in more specialized spinal cord units. If you go to like the Miami Spine Project here in South Florida, in Jackson, you will definitely see individuals doing this. It's part of their standing programs and it's amazing from an exercise standpoint. But then when you get into T10 and T12, these individuals could do household ambulation, but the key here is that thing is what's in the parentheses. Most of them are still going to choose the wheelchair as their primary mode of mobility. So do not oversee the fact that they could household ambulate with bracing. They will still choose to want to use the wheelchair. And then think of just basic anatomy that you guys have been exposed to throughout all your curriculum. Like L1, what innervations do you have there? L2, you have some hip flexors. Now think about like what part of the bracing you could take away. And you'll see that even at L2, they have partial hip flexors, a little bit of quads, and they'll still choose the wheelchair. Wheelchair even for L3s. Really in the community, what's the only type of like orthotic or brace that we really see more commonly in the community?
AFOs.
AFOs, exactly. And that's where you'll see that you see more community ambulation for like the very, very low levels. But all the other levels, a lot of them will still choose the wheelchair. It's not until like about L5 when you have like the glutes and you have almost a whole foot that almost it would be like a presentation of like a drop foot almost per se. And that's why the AFO would probably be the best bracing for an individual with a spinal cord injury. Does that make sense? Does that give you like a little perspective as to, I also put a video of somebody walking with an RGO, which was Dwight, which I knew from inpatient rehab and everything. And you could just see like how cumbersome. And with the RGOs, the reciprocal graded doses, you'll like put weight on one side and it's a spring-like mechanism to help propel the other leg. So when he came in as a guest speaker, he's like, he's working really, really hard while he's doing this. Is that gait functional? You guys can watch a video, right? You can see the video. It's not functional. It's not functional at all. But what do you think individuals will state that they benefit from this? What are the benefits from doing this?
Being able to like ambulate in small distances, like in the home, or just being able to get up in general, I guess.
Yeah. Maybe, you know, walking down the aisle if one day they get married, you know what I mean? Think from like a psychosocial perspective, like how much nicer that might be. But yeah, they state a lot of like other benefits from other systems, you know what I mean? Like gastrointestinal wise, like digestive wise, they state that the standing programs help them a lot. Blood pressure regulations. There's a lot of benefits. Imagine what I was stressing about, like bone density and like bone mineral content, how good it is to be in a weight bearing position. Just like, as you can see, it's very cumbersome when you add the more dynamic component of walking. And like, if you go on that same lecture that I posted, which is like an extra lecture for you guys, there's like a whole bunch of links of videos too that you guys can go and you can see all the different types of gait trainings, all these. If you go on a lot of these, some of them, and on the voiceover I talk about it, that some of them are other diagnoses like spina bifida ones, and like the swing through is like pretty hard to do. Like you really have to plant and like just swing the legs through, so it's a lot more work. Even just the donning of RGO is very, very intense, and just like coming up to be able to lock out the brace is like super intense. That's like already like a workout on its own. I am exo certified train. I'm exoskeleton trained. We used to have an exoskeleton where I used to work. It is great. It's just very cumbersome. You have to be very well trained to use it. Battery life obviously doesn't go that far per se, and that when the spasticity kicks in very hard, it kind of screws up the whole system. That's just from my clinical experience, and a lot of the clinical trial, a lot of the research behind it, sees the benefits from just like a standing perspective, but not so much from a perspective of them being able to walk or improving things of gait per se. So. Great question. All right, so we touched a little bit upon gait, a little bit upon Asia. What else? Talk to me. If you have questions. Questions.
I kind of have a question, but not related to like content as much.
Okay.
So I'm at the St. Augustine campus, and we don't have access to the PowerPoints that you showed, but they look like really nice. I was wondering if there's like any way that maybe I could get like access to those PowerPoints or something. If there's like a student that could,
Yeah, I just don't want to have any conflicts with your professors, to be completely honest with you. I know I'm being recorded. Can you have your professor reach out to me? Is that okay? Just so that like I want your professor to look at the PowerPoint before like it's, or like if it's available to you, I want it to be available for the rest of your class. Does that sound fair?
yeah, I totally understand.
Okay.
Thing is, our exam is tomorrow, so it's
Oh my
probably,
God.
probably too late for that. But I appreciate that a lot, though. I understand. Thank
I apologize. Oh my
you.
God.
It's cool. It's cool. Thank you so much.
Do you understand like the standpoint of like if I give it to you, like I don't want to put the rest of your class at an
Yeah, 100%.
disadvantage at any sense.
100%. Yeah, I
I'm
totally.
so sorry. I'm so
That's
sorry.
cool. It's cool.
But
Thank
like
you.
it's a great point that you bring up, like if in the future, like we created like those are sub PowerPoints that we created here on the Miami campus. So like we have the generic ones on the asynchronous material, and then we create like sub ones in certain campuses.
Yeah, I
All of
totally.
my students, you see. I'm messing with you guys. I'm trust me, I'm as tired as all of you guys times 500. So I'm also a student just doing my dissertation, but this is the real Dr. Quinones at this time. Questions, concerns. And not only did you guys get the PowerPoint, I put a voiceover to the PowerPoint, so it's even better that you're just not just reading the slides. So I'm sorry, John. I wish I could provide it to you, but I would just need the okay to give it to everybody. Questions?
Nelly's thingy isn't working, so she told me to ask
Okay.
about she said ask about the flaccidity and spastic for bowel and bladder. I guess
Okay.
based on the levels.
Let's do my little mini PowerPoints. Hold on. I'm not sharing my screen right now, right? No, share. Yep. I'm sharing. All right. So these are like the mini PowerPoints that I also have created for you guys that you guys should definitely look at. From a psychosocial perspective, I think that with the guest speakers, we hit a lot of the points and everything that are on here. Definitely need to know your grief cycle. I think we talked about all the rehab. The gentleman did a great job with his presentation about that. Mind you that I never even told him to do that presentation. He created that presentation for like another university that like asked him to do the presentation. And I'm like, hey, come with a presentation. And then the other gentleman, Ben, was like super unhappy that I had not told him about a presentation. He was like, you never told me. I'm like, I didn't expect them to have the presentation. All right, when it comes to normal bladder function, you definitely need to know about not so much about the neuroanatomy. You definitely need to know that for your NPTE and everything, but the neuroanatomy gives you context to why certain individuals, because of the level of their injuries, are going to have one bladder versus another one. So this is a pretty good slide, telling you from a sympathetic and parasympathetic input as to the normal bladder function. We could take this to 5,000, level 5,000 when it comes to neuroanatomy, or I can just simplify it into those terms. This is like a little breakdown of the same thing on top, just from a visual perspective. Some people can read it, some people just see the figures and it makes sense. I know what you are going to more, it's really the division. For this class, you really need to know the division between what leads to like what level of injury is going to lead to a reflective bladder and what type of management would you do for that bowel or bladder management versus what would you do for an areflexive. So reflexive is going to occur in lesion T12 and above. Why? Because of the input that is given from the neuroanatomy, from the loss of cerebral control, the reflexive activity. So avoiding involuntary and incomplete. So there's going to be a reflexive bladder. So it's T12 and above. T12 and above. More lower motor neuron injuries are going to be non-reflexive bladders, occurs in lesions T12 or during spinal shock. Remember that spinal shock, that period that all reflexes are diminished. I know that you're asynchronous as a month, but it's really like about a week or two. This will lead to bladder overflow, overextensions, stress incontinence. So reflexes T12 and above, below T12, you're going to get non-reflexive or areflexive bladder. So you even have charts, and the charts are great. So you see, it gives you spinal shock, gives you areflexive, reflexive, and then these are, say, no message, no sympathetic. And then the gentlemen, they kind of like alluded to it a little bit. However, note, we had incomplete spinal cord speakers. So it's a little bit different than from complete spinal cord injury. So just keep that in mind. Just know that those levels. Are you going to have a question on your exam that it says about those levels? 100%. 100%. Definitely know all the implications about it not being well managed, because it could become, like what we talked about with autonomic dysreflexia, it could become a medical emergency. UTIs are pretty bad. One of the gentlemen who I did the half marathon with, he was having a UTI. Well, some of you guys met him at the para-jiu-jitsu event on the weekend. He was having a UTI that same week of the Miami marathon, or the half marathon that we did, and I was like, you need to help like with thermal regulation. So like I gave him like a whole bunch of information on that. This slide here on complications, you don't really need to know. This is like me and my love for differential diagnosis wise, and it was in your O'Sullivan textbook, so I had to share it. More you should focus on this one as well, this slide too. I don't know if this is answering your question, Nelia, but these are like the main parts that you need to focus on. From a bladder management, like what do you do? Like for areflexes, like spinal shock, you're gonna use an indwelling catheter. For areflexes, you're gonna do intermittent cathing. Remember, even with the incomplete injuries, what did they both say that they did catheterizations, right? Because they were what, like C6 and T6 or T something level, right? So those are injuries at or below, like those are incomplete. That's why typical with injuries at or below T12 is a reflexive. Oh yeah, and then reflexive at the cervical and thoracic levels. All right, with reflexive, you might have reflexive voiding. So these pressure, they could press pressure on their abdomen or valsalva, and that can help them with the contraction. Remember, reflexive, you're gonna have some reflexes. A reflexive, they'll do intermittent cath every 4 to 6 hours, but reflexive can also cath as well. So keep that in mind. But they'll have more the reflex voiding. That's where the main difference between the two are. Versus a reflexive, they're not going to have that reflex that they can really void with the valsalva with the reflex of applying the pressure. Suprapubic catheters are pretty cool, especially for like long-term management. You'll have I've met spinal cord injury individuals who are like, oh, I'm scared of needles, so they don't cath, so they'll do like condom caths or they'll do other things. Let me see. This one's another pretty important one. Intermittent versus indwelling. Typically in more acute settings, they'll have indwelling, and typically hope to over time, some levels of injuries cannot really cath, so they will have like indwelling catheters. Like Steven had it, he's with a complete C6. Normal bladder function, you really just need to know these charts. Same thing, areflexive for injuries at or below T12, reflexive for cervical and thoracic. I don't go into such crazy detail when it comes to your exam, when it comes to this. Just know the levels and what is best, or like what would promote a better bowel management program. I'm pretty sure there's an question on this. Like, what did it say? Like, exercise is recommended. A lot of us, if we go take a run or we go work out, what happens? We like rush to the bathroom. Same thing with spinal cord injury. So like, that's how like you can even like, sometimes, not that I would sell physical therapy, but I'm like, these are the benefits of actually, it's not just from a functional perspective. It can lead to all these other systems. Warm drinks. I don't know, the cocktail special where I used to work at was hot prune juice. That'll send you to the bathroom, or like hot coffee, teas, certain things. So like, keep that in mind. Just the toilet transfer would sometimes initiate the bowel management program with individuals. I told you I would do PT at 10:30. My OT would get it at 1 o'clock, and then we just sit them on the toilet. I remember those toilets that we showed with the Rojo cushions and stuff like that. That's all for like improved pressure relief. And just sitting in the toilet sometimes makes you want to go to the bathroom. So just keep those in mind. Sexual function, we hit upon that with the guest speakers. Told you that most of them would want to have sexual function rather than walking. Sometimes that's what I hear from subjective sometimes. Just, you should know this chart right here for sure. Like from a complete standpoint, like only 1% could really reach ejaculation. So that's a big thing when it comes to fertility and everything, versus incomplete, look, 25%. So like, know these numbers. Like, just, you don't have to know that it's exactly 1%. Just know that there's a very low likelihood of that, of ejaculation with that. Or like, what would a complete injury do more, psychogenic or reflexogenic? That's a big difference. Is a 0 or a 90%? Definitely much more reflexogenic. So like, you need to know those differences. I don't think, oh yeah, and the PLIS model, that's a big one for the exam too. Even on the other campuses, even if there's other people from other campuses on here, our questions are very similar on most campuses. And I added little case studies as well in the back. So if any of you guys want to do the case studies and like send me like or I could, you know what I can do? I could just put like a discussion post, and then you guys can just add it on there, and then I'll put like yes or no, and then everybody can see it. That might work better, I think. You guys are, I haven't done one of these review sessions now. I realized that when I started the review session, I go over all the material. So, so much for not doing a PowerPoint. I should just, any other ones? I know you guys you've hit gait, bowel and bladder, Asia. What else?
How in depth do we need to know the outcome measures? There's like a chart with like 8 of them.
Yeah. Just know what each one really tests.
Okay.
Like the one for walking versus what would be more appropriate for complete versus incomplete injuries with the walking test. Which one is the one that compares to normal?
Okay. Thank you.
No problem. I think one is called like the ABLE scale. I think it was developed by somebody in another campus as well. You don't need any cutoff for my class. No cutoff scores, no nothing. Just know what they would be applicable. So like if they gave you like a patient case or something, you would know what to apply, which one to best apply. Great questions, by the way, honestly.
For wheelchairs, do we have to know like what spinal cord level goes in what wheelchair or what? Like how?
You definitely should know the charts about like not really charts, but like know the basics of like what patient would benefit more from a manual versus a power wheelchair, like what levels of injury would be able to propel or not propel a wheelchair. Like a C6 with hand rim projections could propel, C7 for sure, like know that. Oh yeah, make sure you look at all like the ascending and descending curbs, like how do you really ascend curbs, how do you descend curbs. I know we didn't do any wheelie training or any of that, but make sure that you know that you look at all those videos of ascending and descending curbs. There are some questions on that. To those of you that are not my students, like they don't know about all my side conversations, but those that are my students, I had literally like left Neuro 3, went to go treat one of my patients that lived like 2 blocks away from here. One of them had a cabbage ×3. And I swear that for those of you that were in my PCM, my patient care management 2 class as well, oh my God. For as much as you like reiterate sternal precautions, he's only been like 2 weeks and he didn't go to cardiac rehab or anything. Like I am cardiac rehab at home. He broke every single precaution. Like literally, like I was walking him and like he goes to like turn off the light and his hand gets like stuck. I'm like, what are you doing? Like, and like I try not to make a big deal because if his wife is my patient too, and like she goes like crazy on him, and then they start arguing, and I'm like, wait, you need to calm down. You just had like a cab, like you need to calm down. You guys cannot be bickering at each other. So I try to make not a big deal, but I'm like, this guy's like not moving in the tube, like just moving really outside the tube and getting stuck while turning off the light, just to let you guys know. It's not easy. It's not easy. So everything that we taught you guys in PCM2, I swear to God that like it comes out in real life. It really does. I have educated this man, I don't know how many times. I literally text him the precautions when I'm in school. So, like, I'm here and I'm like, remember, don't, cross your arms. And like they're almost like family. And the number one thing that I see people break precautions is when they're like, oh, it's so nice to see you. And they try to like give you a hug. I'm like, oh, just the starting of the hug is bad. Like, all right, quick questions. Talk to me. We're not at PCM2. We got to finish Neuro 3. For those of you that are not my students, you guys do not know about all my extrain, my thoughts that go on. No more questions? Look, they have their exam tomorrow. You guys still have one more week more than them. My course evaluations. I'm messing with you guys. Extra PowerPoints, voiceover PowerPoints, and an extra week to study for an exam. Because yeah, it should be technically Wednesday, but it's the other week. Or it is the other week. Which helped you guys out because I heard you have peds on Friday, right? Yeah. You see, my schedule worked. You're all good. Trust me. Just, the biggest mistakes that I find on the exams are those things. The Asia scoring not being on the correct side. Make sure you look at the gait PowerPoints and like the sequence of how they do the gait training and like what principles they want. Like they don't want upper extremity. They don't want that. They look at that as a compensation. So just look at those because it goes a little bit different than what you've regularly been taught in neuro classes. So make sure you look at those. I find the most questions that students miss are in those areas, especially from the gait training section. Besides that, whenever I've met with students after the exam, it's really like, Dr. Quinones, I can't believe I didn't put the right and the left right. Oh, Dr. Quinones, I knew that that was an areflexive bladder. Like, oh, like I usually get like those type of comments. Look at like what are the most common complications after a spinal cord injury. So I'm gonna think off the top of my head. What are the questions? Yeah, those are kind of the main ones. You guys tend to do really well on these exams, to be honest with you. And don't change your answers. Go with your first answer. Don't change them. But make sure you read the questions. Read the questions, read the answer. Well, I don't know. My test taking strategies is I read the answer choices because the answer choices are already giving me an idea as to what I'm reading in the actual question. So I read the answer choices first, but you guys all have different strategies. Rachel, anything?
Do we need to go, sorry, do we
No?
need to go into depth with the like respiratory management?
I would look at it. You might have, I told you, like, when I had the review book open in my hands, yeah, maybe some like knowing like what type of like the coughing or what type of breathing. Definitely look at some type of the airway things that I did not cover. And I think your asynchronous might touch upon it, but I would go to your O'Sullivan. The O'Sullivan chapter on spinal cord is not that bad. It really is not. It's not too bad.
Okay, thank you.
Yeah, no problem. But they're like, but I have Dr. Keenan's PowerPoints. Like, what do I need? O'Sullivan. Like
Exactly.
they base your NPTE on. I know my PowerPoints are based on it, but I read the chapter. I would suggest they like the spinal cord. They like to ask it a lot on NPTs. I know that after this we don't touch upon spinal cord anymore, but try to keep that information for when you go study for your NPT. It's like great questions to get because they're like pretty straightforward. Pretty straightforward. I told you that for my NCS, the majority of the questions were all on spinal cord, wheelchair propulsion, and how to prevent, like, not just on wheelchair propulsion, on anything on how to prevent, like, chronic insufficiency of the shoulder. Like, that's what all the questions, and it was, like, very straightforward questions. that you want to get those questions right. And then the other ones that don't make any sense, then those are the ones, you can take a chance on. But the ones that you need to know. Anybody else? Everybody's quiet. This is for you. So if nobody has anything, then I'm good jumping off. To those of you that have your exam tomorrow, I wish you the best of luck. Next time I'll just put all my slides together because it seems to be that I still went over them regardless. So I will that. And then for my class, I'm gonna post an Asia B. I didn't think I really showed you guys an Asia B. So I'll post an announcement with an Asia B so that you guys can see what an Asia B and the difference between an Asia B and an Asia C. Just to clarify that a little bit for all of you. Sound good? Because I have other examples. But I think that we're all good. I think that
Thank you. Have a good
for
night.
vestibular, no problem. For vestibular, Dr. Christian Garcia, he'll run a review session for you guys. And then we'll do post-concussion when I come back from CSM. So I'll see you guys next week. Hopefully I will get here on Sunday night and I'll be here for Monday's class. No, I'll be here. Oh no, we don't have class on Monday. Just kidding. We have class Wednesday. Wednesday. That's true. Monday, there's no school, right? Yeah. Even better. Bye. See you all.
Thank you so much, Dr. Quinones.
Bye.
Thank you so much.
Thank you.
Good night.